Thank you so much for the opportunity to share a very important topic, which is microvascular dysfunction. To me, oftentimes microvascular dysfunction is not the typical viewpoint of coronary artery disease. Let me explain more. Basically, coronary microvascular dysfunction is defined as persisting symptoms of ischemia combined with some sort of objective evidence of ischemia, such as abnormal stress testing or evidence of acute myocardial infarction. Confirmation of microvascular dysfunction occurs with coronary angiography, in which no obstructive coronary artery disease is identified. Either the vessels look normal or there's less than 50% epicardial luminal stenosis. It is a significant problem in which 3 to 4 million men and women have evidence of ischemia with non-obstructive CAD. And oftentimes you can see in the literature the term is INOCA. Women are more likely, though, to have microvascular dysfunction and are 4 times more likely than men to be readmitted for anginal symptoms. One of the most widely studied cohorts of women with this syndrome is in the WIC cohort. And after 10 years of follow-up, anywhere from 6.7% to 12.8% CV death or MI rates were identified in these women that either exhibited no CAD or had non-obstructive CAD. Why does this occur? Oftentimes, as physicians and healthcare providers, we look at what's most obvious and really what types of tests kind of direct us in a certain pathway. And in this case, we oftentimes rely on coronary angiography to look at coronary artery disease. However, what we're doing is we're focusing on epicardial vessels, which we can easily see on angiography, but yet contribute only 5% to the total resistance of the coronary circulation. It's really at the level of the arterioles and the prearterioles in which 80% of the total resistance of the circulation lies. It's really here where we start to regulate blood flow. And remember, at baseline levels, the myocardium is extracting nearly 100% of oxygen. So extracting more oxygen isn't going to fix the problem if the metabolic needs of the tissue require more oxygen. We're going to be increasing flow. And it's this mismatch between metabolism and oxygen demand with blood flow that we develop symptoms of ischemia. The pathophysiology is incredibly complex, in which we already know from an epicardial, if we focus on the epicardial vessels, we're used to seeing focal atheromas and, obstructive lesions in which we're more than comfortable treating with stents and sometimes medication. But these risk factors generate an environment in which oxidative stress and autonomic dysfunction not only act at this level, but also again in this the workhorse of the microcirculation, in which impaired nitric oxide bioavailability, increasing amounts of endothelin and thromboxane, which are potent vasoconstrictors, and again, oxidative stress and reactive oxygen species make the smooth muscle and the endothelial cell signaling dysfunctional. How do we diagnose coronary microvascular dysfunction? Mainly 2 different ways. We invasively will look for coronary flow reserve, which is the ratio of maximum flow to resting flow after the administration of a bolus of adenosine. However, coronary flow reserve encompasses the epicardial vessels and the coronary microcirculation. If we want to try to tease out both vascular beds, the best way of doing this is a graded intracoronary acetylcholine infusion. So a lower dose of acetylcholine allows us to measure coronary blood flow and allows us to really look at the degree of endothelial dysfunction. A good non-invasive test is cardiac MR as well as cardiac PET. In these images, you can see there's delayed enhancement, which is a key to potential ischemia. And during a CMR stress test, what we can see on this pixel view is that you have subendocardial ischemia. What does this mean? Well, if you look at PET-related cohorts of patients, we've seen that if we look at coronary flow reserve that's less than 2, that in people who have normal stress tests, that a little more than half of the women in the cohort exhibited reduced suggestive of microvascular dysfunction. Men were at nearly 50%. How does this translate into annualized MACE? You can see if we risk stratify by CFR, you can see anywhere from a 5 to 7% annualized MACE increase versus those with greater than 2. How would we diagnose this? If there's evidence of ischemia, what you'd want to do is your standard workup for CAD. Rule out obstruction, and if it's there, treat. If you don't have evidence of ischemia, then I would recommend using one of the PET or CMR tests that I alluded to earlier. If it's positive, you're going to, again, send that person to look for obstructive CAD and potentially do some of the cath lab measures of intracoronary adenosine or acetylcholine. You already have positive reactivity. If there's no obstruction, treat for microvascular dysfunction. If both tests are negative, then I would look for other causes. So how do we manage patients with coronary microvascular dysfunction? Obviously, as I alluded to, the mechanisms underlying endothelial and smooth muscle cell dysfunction make treatment difficult because they're very complex. However, we do have proven therapies that will increase coronary flow reserve and improve symptoms, such as statins, ACE inhibitors, as evidenced within the WIC cohort to increase CFR and reduce fibrosis, as well as adding on aspirin therapy. And also lifestyle changes and cardiovascular risk reduction are key. Therapies that are not as well proven but may benefit and seem logical to add if necessary would be beta blockers, nitrates. And again, we do need a significant number of randomized trials. Ranolazine was found to be ineffective only once it reached the level of a randomized controlled trial. So key points to remember: cardiovascular disease is the leading killer of Americans. Microvascular dysfunction is a serious cause of MACE and should be investigated robustly. It disproportionately affects women, so be on the alert when you have women present with anginal symptoms, and if they have non-obstructive coronary disease, be aggressive down this pathway. Strongly consider vasoactive testing if they are symptomatic and manage their cardiovascular risk factors, as well as encourage participation in clinical trials. Thank you very much for the opportunity to share my passion for microvascular dysfunction, and I look forward to the rest of the talks today.